So look, at the moment with athletes that injure themselves, typically from a rehab point of view, you'll see them on the ground, they will fall down, there'll be some pain. Normally how it's happened, there's some idea in our mind that it could be more serious than just a simple knock to the knee. They'll then be taken off the pitch. There's some physical tests we can do to determine whether it's the ACL may be involved, but generally the athlete or player the next day will be assessed through an MRI scanner, and that will show the extent of damage to the ACL. If it's a full thickness tear and the player is wanting to return back to a pivoting, twisting, jumping sport and at risk of being contacted, the general consensus at the moment or presumption would be that they would need surgery, and they would be referred to an orthopedic surgeon and they'll often be under the knife within a few weeks. So in regular Australians, it's a little bit different. It depends really. With Pete, you've got paediatrics, you've got elderly, you've got people that are more active, and those that are sedentary. Generally, these injuries happen in those that are younger, so younger, active, athletic individuals who will injure it playing sport. And generally, again, the presumption is that they would need a full reconstruction in order to return back to a pivoting type sport. And I think if you were to ask or assess anyone in general public, this would be what their perception would be. So in the past 10 years, really the incidence or occurrences of ACL tears seems to be increasing quite significantly. And the reconstruction rates are also increasing significantly, whereby now in Australia we actually have the title of the highest rates of reconstruction in the world. And this is obviously a massive cost to society. In Australia, ours are about 90% of ACL tears will be reconstructed, whereas in Scandinavia and Northern Europe, the rates are significantly lower, so they're about 50%. And it's more of a physio-first approach there, and they have more up-to-date models, and the tracking of injuries is a bit better there as well. So what's driven these rates has been the awareness of the procedure and the availability of it. In Australia, you can get a free GP appointment or rebated GP appointment. You can get a scan, orthopedic opinion and a surgery, yet you have to pay for rehabilitation as treatment. And so I think those elements have helped to increase the rates. So look, it's a good question, like how did we come to this point in history? I think really it boils back to assumptions and theory. So we've come out of a model of healthcare that's been very much based on the anatomy itself, and if we resected a ligament like the ACL and saw that in a particular direction it was unstable, we would then assume that if we were to get a patient in weight bearing, that they would have an unstable knee, and they certainly wouldn't be able to theoretically perform at a high level through their knee, but then also day-to-day tasks might even be difficult. And so from there, we've developed surgical techniques to provide some stability to the knee, and we've had powerful healthcare systems that have been set up to kind of perpetuate this and continue that. And then really in the past 30 or 40 years, all of the research has been heavily biased towards surgery. So the energy, the emphasis, the costs and the funding has all really been towards surgical techniques and graft types. And this is all culminated in us believing that surgery is necessary to return to normal life and indeed sport.